there that transform the debate so that what we're talking about is empowering individuals to make choices that meet their particular needs. That's what the state of Utah is doing. That's what the Price bill is doing. That's what the Shadig bill is doing. And the sad part about our debate is we're not allowed to discuss those on the floor in any form other than in a special order in the evening. Look, we weren't here in session on Monday. We only did a few suspensions on Tuesday. We adjourned very early on Wednesday. It was a wonderful day. I was happy to go outside. But we adjourned early. Those are times in which the Price bill and the Shadig bill should be brought to the floor and allowed to be debated and discussed and voted on to see if indeed these other kind of options that we have, these other kind of programs that inspire and empower individuals to make choices for themselves have some merit. Now that's what we should be doing here. Instead, the entire debate has been moved off the floor, out of committees, behind closed doors. That does not help. And indeed, you have hit the objective. If we choose the wrong choice and have one federal program that's going to be superimposed on everyone, we have the chance of doing great harm to our small business, which is the backbone of the American economy, with 5 to 6 million people losing their jobs. That's what the danger is. We should have an open and honest debate about these other options which try to look uniquely, outside the box, creatively. That's what Congress should be doing. And we're not doing any of that. Back to the gentleman.
Thank you, Congressman. Bishop, Congressman Thompson, when we talk about the safety net that exists today, and you came from the healthcare industry, the first bill that the President signed was the S-chip bill that went 4 times above the poverty level to provide a public insurance program for children. So that's $88,000 for a family of 4, and states could do income disregards and raise the amount up more. We've got Medicaid for the poor and disabled. We've got Medicare for the elderly. In my state, we have 183 community health clinics that, if you look at their website for the 2008 annual report, shows that they had about 400,000 patients in 2008. Not patient visits, but patients that receive preventive care, primary care, dental care, and mental health services. This is in a state of 5 million that is publicly funded. Some of it folks can pay as they have the ability to. It's for the uninsured and the underinsured. We have a high-risk insurance pool in the state of Colorado. For everyone who buys an insurance product pays a premium tax, and part of that goes into a pool for anybody, regardless of their income, that can't qualify for a public program. And irrespective of their pre-existing condition, they receive health insurance that is capped at 140% of the average premium price in the state of Colorado. Can you address to us your view as a former healthcare professional about the safety net that exists in America?
Absolutely, and I really appreciate that question. You know, one of the biggest disappointments, because I came to this body out of health. I thought I'd actually retired from nonprofit community healthcare, which meant my hospital would have provided me a discount on my nursing home bed. But instead, I have the privilege of coming here to work on behalf of the citizens of the Pennsylvania 5th District. And I came here knowing that we've got a pretty good healthcare system, that we could do better, and we could improve it, and improve on all 4 principles: access, affordability, quality, and patient choice. And so I was excited when the President said we were going to work on healthcare. And I get here, you know what we're working on? We're working on access to health insurance. We're not working on access to quality health care. That's what we should be working on. That's what the American people deserve as we work on things like we've been talking about, H.R. 3400 and the different bills that are presented here that would improve health care in all 4 dimensions. But instead, we're talking about health care insurance. And I guess I should have had some indication of that when I looked at the individual that was selected.
Would the gentleman yield for a question?
Absolutely.
Representative Thompson, the bill H.R. 3200 strips hundreds of billions of dollars out of the Medicare system, and it effectively shuts down the Medicare Advantage program. Can you talk? The trustees of Medicare have already said that in 2017, not by 2017, but in 2017, Medicare is expected to go broke. So there's solvency issues in Medicare, and yet we're stripping hundreds of billions of dollars out of the Medicare system. Could you speak to that and its impact on the elderly?
Sure. Medicare actually is a central component of this debate from many different ways. And let me start with the question that you raised. The Democrats' health care bill, the accounting of it, cuts essentially $128 billion from Medicare Part A. Medicare Part A pays for inpatient services. That pays for hospital services. It pays for up to 100 days if an older adult is qualified, in a skilled nursing facility. $128 billion. I have to tell you that most hospitals I know, and I have probably about 20 hospitals in my congressional district, I would say that my hospitals are like many in America, either in rural settings, certainly underserved urban areas. They're lucky to be making a margin of 3 to 4% annually. And to cut $128 billion from Part A will certainly impact, I think what it will do actually, it could very easily move towards bankrupting many of those facilities. Certainly Medicare Part B, which is what is the Medicare coverage that individuals choose to purchase. It helps to pay for physician services. It helps to pay for therapy services if you're as an outpatient. And that is scheduled for $130 billion in cuts for Medicare in order to fund this Democratic health care plan. The Advantage plan you talked about is Medicare Part C. Medicare Advantage is managed care Medicare. And it's essentially a plan where individuals choose to enroll in. It gives them a little more flexibility. It provides them a little more coverage. That's a choice that they make. And the Advantage Medicare plan has really been targeted by my Democratic colleagues, and that's scheduled for within this $133 billion in cuts. And finally, the pharmaceutical program. You know, one of the newest parts of Medicare, Medicare Part D. That's the drug benefit that President Bush put in place here a few years ago. Under the Democrats' proposed health care plan, Medicare Part D, the pharmaceuticals, the drugs, is scheduled for a cut of $20 billion, totaling $411 billion in Medicare cuts. Now, that impacts people. That impacts individual lives. It impacts jobs. In my district, in a very rural district and with rural counties, my hospitals are actually important economic engines. It's a place with some really good jobs. They're economic engines. They buy a lot of resources to operate the hospital. They try to buy them locally to support the local economy. And when you start to make these types of Medicare cuts on facilities, healthcare facilities that are at best in a banner year are making a 4% margin, we're talking about closing those. We're talking about losing jobs. And that's not good for anyone. You would never want to see a hospital close. But in a city, you could make, I guess there's an argument that you close one hospital, somewhere in the city, probably within blocks, you'll find another one. Mm-hmm. In rural America, rural Pennsylvania, you close a hospital, and what you wind up is a commute that makes the difference between life and death.
Would gentlemen yield for a question? Congressman Thompson, we talk about cost shifting, and I know there's cost shifting for uncompensated care, but there's also cost shifting for Medicare and Medicaid, the underfunding of those programs, government programs, which have done much more in terms of cost shifting onto the private insurance market and have had a big factor in escalating premiums. But when we talk about how government sets rates, it doesn't set rates really to the market, as a private company would have to do. It can set rates at an artificially low level because it doesn't have to respond to the market. I wonder if you could address that and why the public option would destroy private insurance.
Absolutely. I see three primary reasons why commercial health insurance is so expensive. And one is we need more competition, and that is allowing a broader pool. I'm really interested in learning more about the model in Utah. It's intriguing. It sounds like a great model to look at. But more competition is important. Secondly, it's the need for tort reform. I talked about those numbers, $126 billion a year. It drives cost up. It drives the cost of providing care up. Therefore, commercial insurance goes up. And finally, there's the necessary cost shifting that occurs. Now, some of my colleagues in this body, particularly across the aisle, when you hear the terms cost shifting, they see that as an evil thing. When you come out of health care, you begin to understand what happens in health care. Because I would have to say the primary reason that health insurance is so expensive is because government creates an entitlement, Medicare, medical assistance, and then from the day one, after they create it, discovers they can't afford it, and they systematically underfund it. So let me talk about the numbers specifically. Medicare, for every dollar it costs that a hospital or a physician has, Medicare pays 80 to 90 cents, 80 to 90%. If it's medical assistance, that's 40 to 60 cents for every dollar it costs. If you just operate on Medicare or medical assistance, a hospital and a doctor you could see is, they have these costs and this reimbursement. They're not going to keep their doors open very long because they can't cover their costs. So what they do is they negotiate with commercial insurance. And commercial insurance average across the nation pays at least 140%. 140% of cost. Now, why do they do that? Well, they do that because in the negotiation process, doctors and hospitals need to achieve that 140% from commercial insurance to offset what medical assistance and and Medicare, what the government doesn't pay. And so that's where the cost shifting occurs, because if you don't get that higher rate for commercial insurance, you're not going to be able to make payroll. You're not going to be able to invest in life-saving technology. You're not going to be able to keep the lights on in the facility. And so the fact is that government creates these new programs with the best intentions, I'm sure, but quickly finds that the costs are just so tremendous that they begin to systematically underfund those costs. One of the biggest concerns I have with the public option, as I read H.R. 3200 and the Education and Labor Committee when we marked that bill up, is that the public option would pay Medicare rates. Medicare rates is 80 to 90 cents, 90% of cost, 80 to 90 cents for every dollar cost. I do believe that the public option will be cheaper than commercial insurance, because the public option will also underfund the cost of health care. And as the public option replaces the commercial insurance that today really funds and keeps the lights on in our hospitals operating and our doctors in practice, we're going to lose health care providers.
Gentlemen, yield back.
I'll yield back.
Congressman Bishop, you've talked about some of the health care reform measures before the Congress, some of the Republican measures, I think you referenced one by Congressman Shattuck, and you referenced another one, Congressman Shattuck and Congressman Price. I think you referenced two Republican health care proposals. I wonder if you can talk about, I think that everybody in the Congress agrees that reform is necessary, that the system isn't working as it should, that people are paying too much for health care, that we need to do more for the uninsured. It's a question of how we get there, and do we do a government takeover of the system by inserting a government-controlled health care plan, or are there market-based solutions? And I wonder if you could give your view on how you see reform.
I appreciate that, and I think the conversation we've had so far with Congressman Thompson is fascinating, because he has explained some of the problem you have when the government steps in to run the system. I mean, if we look back at the history of the Medicaid portion, it does not give us a whole lot of confidence for moving forward and allowing the governor to take a larger role in this area. Since Medicaid was founded in 1965, it has been, the costs have escalated at 2.3% higher than the rate of inflation. Today, Medicare costs 37 times what it cost back then, after being adjusted for inflation. So when Congress first established Medicare, they thought it would cost $238 million a year. That first year it was closer to $1 billion. They projected that by 1990 it would cost $12 billion. The actual number was more like $90 billion. And if, as the gentleman suggests, that the government therefore has taken over those particular options, and you no longer have this cost shifting that you go onto the private sector, the only other option you have in a healthcare system to try and deal with those real costs. Well, you can go bankrupt. But the only other option you have is cutting services that are given,
Correct.
which is why this debate is so significant and why these other bills that we have been talking about are so important that they be debated here on the floor. So people can realize that rather than having the government explain what you can and cannot do, if you simply open up the options so individuals have a choice and become part of the system, there is a responsibility of the consumer as part of the system, then these changes can happen. We have, in every other kind of insurance, you can buy insurance across state lines for auto, for housing. Why not for medicine? A simple change in the federal restrictions would allow that to take place. You can pool for almost everything except in this area. Why not change those restrictions, which is what we're talking about? Why not allow people to buy their own insurance with pre-tax dollars, not post-tax dollars? Why not simply allow a benefit to the small business the way big businesses have for HSAs?